Good afternoon, everyone, and thank you for joining us for today's webinar, You Are the Key to New HPV Cancer Prevention, Understanding the Burden of HPV Disease and the Importance of the HPV Vaccine Recommendation, with Dr. Andrew Kroger from the Centers for Disease Control and Prevention. My name is Rachel Logan, the Training and Technical Assistance Manager at the National Center for Health and Public Housing. This webinar opportunity is provided in part by a grant from HRSA, and it enables us to provide free training and technical assistance to health center grantees as well as other healthcare providers who serve disadvantaged populations. Today's webinar will enable participants to communicate the burden of HPV disease to their patients, schedule the HPV vaccination series according to the Advisory Committee on Immunization Practices recommendations, and to anticipate the concerns of patients and parents with respect to this vaccine. In the United States, about 36% of women who are considered low income have spoken to their doctor about the HPV vaccine, which indicates that majority of low-income patients aren't getting the information they need or talking to their healthcare provider about the vaccine. There's also a disparity, as you see below in this small chart, between ethnicity and race and income levels. Also, there are cervical cancer disparities as well that pertain to race, and minority populations are known to have higher rates of incidence and to also have higher mortality rates from cervical cancer. I would like to remind all attendees that today's webinar will be recorded and made available via email after the webinar presentation and posted to our website. Before I pass the presentation to Dr. Kroger, I will give him his formal introduction. So Dr. Kroger is the medical officer for the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention. As one of the traveling trainers in the Education, Information, and Partnership branch, Dr. Kroger has given multiple presentations on topics ranging from immunization updates to pandemic influenza preparedness. Most notably, Dr. Kroger is the author of the newest edition of the CDC's General Recommendations on Immunization, and he is also involved with some of the new distance learning activities of the branch, including the Current Issues and Immunization series that is delivered through net conferencing. Dr. Kroger trained in pediatrics for 2 years at Rainbow Babies and Children's Hospital in Cleveland before transferring to Emory University, where he specialized in public health and preventive medicine. He received Joint Doctor of Medicine and Master of Public Health degrees from Yale Medical School and Yale University School of Epidemiology and Public Health with a concentration in international health. Thank you, Dr. Kroger, for joining us today.
Thank you very much. I'd like to thank the National Center for Health and Public Housing for the opportunity to give this presentation. I do want to make a financial disclosure that I have no conflict or interest with the manufacturer of any product mentioned in this presentation. I do need to make one off-label disclosure. I will discuss the use of HPV vaccine in a manner that conflicts with the HPV package insert from the Food and Drug Administration, or FDA. CDC publishes its guidance based on the Advisory Committee on Immunization Practices recommendations. That's ACIP for short. These recommendations sometimes conflict with FDA language in the package insert. Usually the ACIP recommendation simplifies and harmonizes between different brands of the same product. And when I come to an actual recommendation that conflicts, I will make you aware of the conflict. Rachel Logan already mentioned the objectives, so I will move on to my presentation. I will begin with a description of the burden of HPV infection and disease. So HPV stands for Human Papilloma Virus, which is the most common sexually transmitted infection. Almost all females and males will be infected with at least one type of HPV at some point in their lives. It is estimated that 79 million Americans are currently infected with 14 million new infections every year in the United States. New infections are most common in people in their teens and early 20s, and most people never know that they have been infected women really have their infections diagnosed following Papa Nicolau or Pap tests, but the vast majority never know that they have been infected. HPV transmission occurs through any type of intimate sexual contact. Exposure occurs across mucous membranes through vaginal or anal intercourse or oral sex. The risk of HPV exposure occurs in young adulthood with sexual debut. 50% of high school students have already engaged in sexual intercourse even in the 9th grade. The risk of HPV infection and the risk of progression to high-grade lesions and cervical cancers increases with multiple partners. So that being said, even teens and young adults can sometimes be considered high risk, as many as 24% of high school seniors have had sexual intercourse with 4 or more partners. This graph plots data from college diary studies that measure the cumulative incidence of HPV infection over time. Now, the yellow line represents males and the green line represents females. And so you can see the cumulative infection rate on the vertical axis and months since first intercourse on the horizontal axis. And so what you can see from this graph is that acquisition of HPV is rapid. Really 30% incidence over the first year, 12 months after sexual debut. The slope in males is particularly steep. Young women are at risk of HPV acquisition from their first male sexual partner. So this gives you a sense of the rapidity of the risk. I've already mentioned that HPV can be transmitted in numerous ways, oral sex intercourse, so it's no surprise that HPV can be found in virgins, defining virginity as intercourse. A study in the Journal of Infectious Diseases looked at the frequency of vaginal HPV in adolescent women without prior vaginal intercourse, and HPV was detected in 46% of them. And then 70% of these women did report non-coital behaviors that in part explain the genital transmission. There are a bit now about the microbiology of HPV. There are more than 100 subtypes of human papilloma virus, 40 of which are considered genital HPV. Of these 40 types, genital types, about half of those 40, or 20, are considered high-risk types, responsible for causing cervical cancer and other anogenital cancers. In 90% of these infections, the infection does resolve without any complications, but it's that remaining 10% in which the infection can become latent and can reactivate, causing the high-grade lesions which can lead to cancer. And so, and there are different kinds of cancers. I'll talk now about cervical cancer. This is the most common HPV-associated cancer among women. In 2008, there were 500,000 cases of cervical cancer and 275,000 deaths worldwide. In 2011, in the United States, there were 12,000 new cases and 4,000 deaths. Now, many people think of cervical cancer as affecting older women. However, while 24% of the cases occur in women between the ages of 45 and 54 years, around 25.9 or 26% of cases occur in women between the ages of 35 and 44. And you can see that 14% of those occur in women between 20 and 34 years. And remember, this slide is not HPV infection. This slide is cervical cancer. So you can see that it can affect younger women as well. This graph shows the age-adjusted rate of cervical cancer among different races and ethnicities. Cervical cancer affects women of color and their communities more than their white counterparts. Women of color are often diagnosed with cervical cancer at a later stage. than white women. Black women are more likely to die from cervical cancer than women of other races or ethnicities, possibly because of decreased access to Pap testing or follow-up treatment. Hispanic women have the highest rates of cervical cancer in the United States. For example, for every 100,000 women living in the U.S., about 11 Hispanic women are diagnosed with cervical cancer compared to only 7 non-Hispanic women. So 11 out of 100,000 compared to 7 out of 100,000. So you can see the rate is higher in Hispanic women. Now, HPV not only causes cervical cancer, but can cause oral cancer, anal cancer, vulvar cancer, penile cancer. All of these cancers are on the rise in the United States, disproportionately affecting different races and ethnicities. Between 2000 and 2009, oral cancer rates rose 5%, 4.9 or 5% for Native American men, and 1% for Asian men. Anal cancer rates doubled between 1975 and 2009. Vulvar cancer rates have risen for white and African American women, and penile cancer rates have increased among Asian men. This pie graph depicts data from the National Cancer Institute with contributions from the American Cancer Society and CDC as well. Showing the average number and types of HPV-associated cancers by sex between 2005 and 2009. So as you can see, women suffer a greater burden of disease than men overall, 20,000 cases compared to 12,000 in women compared to 12,000 cases roughly in men. And as you can also see, women are predominantly affected by cervical cancer, whereas with men it's oropharyngeal cancer that causes most disease. In the 20 years between 1984 and 2004, the proportion of oropharyngeal cancers believed to be caused by HPV, as opposed to other causes like tobacco or alcohol, has changed. The prevalence of oropharyngeal cancers caused by HPV increased from around 16% to around 72% of all oropharyngeal cancers. So that's the percentage of the cancers caused by HPV. The population level incidence of HPV positive cancers increased 225%, while HPV negative cancers declined by 50%. So if these trends continue, the annual number of HPV positive oropharyngeal cancers is expected to surpass the annual number of cervical cancers by the year 2020. Cervical cancer, in some cases, is a treatable disease, but cervical cancer prevention and treatment have serious complications as well. Sometimes cervical cancer can only be treated by hysterectomy with resultant infertility. HPV causes 12,000 cases of cervical cancer, but causes 1.4 million cases of pre-invasive disease, what gets detected on screenings, and that is often treated by procedures like cervical conization and loop electrosurgical excision procedures. And these can lead to conditions such as cervical stenosis and cervical incompetence, which have complications of their own. They can cause preterm delivery, low birth weight, and even death. The impact is not only on the mothers and the infants first, but also on neonatal intensive care costs. So with that discussion of the burden, I'd like to now talk about the vaccine, HPV vaccine, licensed in 2006 for prevention of HPV infection. And we, again, it's a prophylactic vaccine that prevents infection by HPV. It is what we call a fractional inactivated vaccine, which is made by genetically expressing a recombinant L1 capsid protein. So the vaccine does not really consist of the microbe itself. It consists of a protein, and these little proteins cluster to form a virus-like particle. It's non-infectious, it's non-oncogenic, it doesn't contain DNA, it contains the protein. So it can't cause disease on its own, but what it does do is it generates a very strong immune response, producing higher levels of neutralizing antibody than natural infection. And you can see a schematic of what a virus-like particle looks like there on the right side. So what are these virus-like particles are specific to the certain strains, the particular strains of the organism, and the vaccine contains virus-like particles from strains 16 and 18, which cause 70% of cervical and anal cancers in men and women. There are two other strains, type 6 and 11, which cause 90% of the cases of genital warts and 90% of cases of what's called recurrent respiratory papillomas. This is a condition that affects newborns born to mothers actively infected with HPV. It's a condition that causes laryngeal warts. These can be very painful and need several surgeries to remove them. There are two formulations of HPV vaccine, and this chart kind of describes the two. First, there's HPV-4, the quadrivalent HPV vaccine manufactured by Merck under the trade name Gardasil, contains virus-like particle from strains 16, 18, 6, and 11. So those are the ones most common for both high-risk and low-risk conditions, respectively the cervical cancer, anal cancers, penile cancers, and their precursor lesions are the high risk, and the genital warts, recurrent respiratory papillomas, are the low risk conditions. So it contains types for the preventions of those conditions. Gardasil is licensed for women and men 9 through 26 years of age. The other vaccine is a bivalent HPV vaccine manufactured by GlaxoSmithKline, which contains virus-like particle from strains 16 and 18. It is licensed only for females 9 through 25 years of age. Here is what the packaging looks like for the two products. Gardasil is produced through recombinant technology using yeast as a vector. That's how they make the virus-like particle. So as you can see, there's the second row are contraindications. Someone with an anaphylactic allergy to yeast would have a contraindication to Gardasil. We'd be concerned about them having anaphylaxis to this vaccine. For Cervix, our contraindication is someone with anaphylactic allergy to latex. The pre-filled syringes contain latex. So someone with anaphylactic allergy to latex could have the single-dose formulation, but not the pre-filled syringe. Both vaccines are given as a 3-dose series. Per the package insert, Gardasil should be given at time 0, time 2 months, and time 6 months. Cervix should be given at time 0, time 1 month, time 6 months. HPV vaccines have very high efficacy, around 93 to 98% for the prevention of high-grade cervical lesions. This efficacy is only seen without evidence of previous infection with vaccine types. The very important point, this is a vaccine for prevention. It's not a treatment for current infection. It was studied, it was looked at in people that were already infected with the vaccine type strains, and this vaccine has on the order of 30% low efficacy against existing disease. So it should be used for prevention. However, the vaccine, I don't mean to say that the vaccine shouldn't be used if someone already has a history of infection, because the manufacturers also looked at people that had a previous infection with one of the vaccine strain types, but not another. And the vaccine was very effective against the type for which the person was not previously infected. So there's benefit that is definitely obtained from this vaccine, even if there is a history of past infection. And plus, most of the time, people have these histories of past infection without even knowing which strain it was. So there is definitely a benefit to this vaccine for someone that has a history of infection, and that's why the recommendations, as you'll hear about soon, are quote, universal in a sense. In men, Gardasil reduces the risk of anal cancers and genital warts by around 89 to 90%. Not as high as the efficacy against cervical cancer, but very, very high efficacy as far as vaccines go, so effective for men and women. Now, ACIP recommendations for the use of this vaccine: routinely, males and females between the ages of 11 through 12 years. For those that can't be vaccinated at those ages, if it gets missed, ACIP recommends catch-up vaccination of males through 21 years of age and females through 26 years of age. Providers may use the vaccine for 9 and 10-year-olds as well. The vaccine is licensed as young as 9, both vaccines. Likewise, providers may use Gardasil to vaccinate males 22 through 26 years of age routinely. There's not a full recommendation from CDC to use the vaccine in males 22 to 26 years of age because the burden of disease is not, as high in that age group, but providers may do so. Now, for females, either Cervarix or Gardasil may be used, and this is off-label in the sense that we recommend through 26 years of age, but Cervarix is only licensed through 25 years of age. But, again, ACIP harmonizes. Either one can be used for catch-up through 26 years. Gardasil is the only vaccine that was studied for additional cancer types beyond cervical cancer, such as vaginal cancer, vulvar cancer, anal cancer, and genital warts. And that's reflected in the information and the package insert and the indications. For males, only Gardasil is licensed, and only Gardasil is recommended by ACIP. It's routinely recommended for boys and men 11 through 12 years of age and as a catch-up through 21 years of age. Providers, again, as I mentioned, may use the vaccine in young men 22 through 26 years of age. There is a full recommendation to use the vaccine in men 22 through 26 years of age if a man is identified has risk factors for which there's a high burden of HPV disease and cancers. That's where the efficacy is shown. That's where we have the data to show the vaccine works. That's why the full recommendation. And so these risk factors are men who have sex with men, including those that identify as gay or bisexual, those with HIV and immunocompromised. So they have the full recommendation to be vaccinated through 26 years of age. The recommendation for both formulations of vaccine is time 0, time 1 to 2 months, and time 6 months. So again, the timing of that second dose, 1 to 2 months, is off-label as well because each package insert has one specific time listed. But ACIP says you can use either of those time points for either vaccine, 1 or 2 months after the first dose. Now, doses can be given on an expedited schedule, but this is not preferred. What this expedited schedule is shown by the minimum intervals. It could be given as rapidly as an interval of 4 weeks between the first and second dose, 12 weeks between the second and third dose, but then 24 weeks between doses 1 and 3. So you have to keep all 3 of those intervals intact, no faster, or we won't count the doses as valid doses. But really, we prefer you use 0, 1 to 2 months, or 6 months. The best data, the strongest immunogenicity is derived from spacing out at least that much. But we will count the doses if you use an expedited schedule. And as I've mentioned, the minimum age for the first dose is 9 years of age. A lot of attention has been given to HPV vaccine safety. As this vaccine is an inactivated vaccine, the most common adverse reactions we see are mild local reactions. For serious adverse events reported, there's no unusual pattern or clustering that suggests that these adverse events are adverse reactions or even anything caused by the HPV vaccine. This vaccine is considered as safe as other inactivated vaccines given at the same time, like the meningococcal conjugate vaccine or the tetanus, diphtheria, acellular pertussis vaccine. I've got those abbreviations there, MCV4 or Tdap. 57 million doses of HPV vaccine have been distributed in the United States since 2006, and no serious safety concerns have been identified. And the sources that we have used to do these studies, because we do safety surveillance, we're always looking for things. This is conducted by a program called VAERS. We have providers submit passive reports of any outcomes they see. We want to hear about it, and so we receive those reports. And the Vaccine Safety Data Link is a way to do active surveillance where we can, we have relationships with managed care organizations that collect data, outcomes data on people that have been vaccinated and those that have not been vaccinated, so we can do controlled studies using that data to see if an outcome is caused by the vaccine. Those are ongoing monitoring programs conducted jointly by CDC and the FDA. Likewise, manufacturers have ongoing post-licensure commitments to monitor the safety of doses. They're doing this in pregnancy now. It's an inactivated vaccine, so there's no reason to think the vaccine would be unsafe in pregnancy, but we don't have that data yet to recommend it in pregnancy. But studies are being done. There are also long-term follow-up studies being done in the Nordic countries. The World Health Organization and the Institute of Medicine are two other agencies that have published official reviews on the safety of HPV vaccine. So as far as contraindications and precautions, I've talked about contraindications already. You can see it's a severe allergic reaction or an anaphylactic reaction to a component of the vaccine. A precaution is a condition where providers have to make a decision if they think the risk of withholding the vaccine. If someone has, for instance, moderate or severe acute illnesses, this is a precaution for all vaccines. In this circumstance, a patient is going to recover, most likely, from the moderate or severe acute illness. So we always say, generally, you can wait to give a dose of vaccine until the patient is better. I've mentioned pregnancy previously, so we recommend deferring HPV vaccine during pregnancy. Inadequate studies of the vaccine in pregnancy, that's the reason why. If a woman is found to be pregnant after initiating the vaccine series, remaining doses should be delayed until after the pregnancy. With a delay, there is never a need to start over. Just finish the remaining doses. That's kind of a general recommendation we make for all vaccines. Again, there's no indication for any intervention. There's no, unlike live vaccines, there's not even a theoretical cause for a safety concern. So CDC ended up recommending deferring the dose because it was not FDA licensed for use in pregnancy. But if a dose is administered inadvertently during pregnancy, there is no indication for intervention. It can be reported, it should be reported to the manufacturer at the telephone number found in the package insert. We now have data showing the impact of vaccination. The National Health and Nutrition Examination Survey demonstrates a reduction in the prevalence of HPV in 14 to 19-year-olds from 11.5% in the pre-vaccine era, which is 2003-2006, to 5.6% in 2007-2008. I'm sorry, 5.1% into 2007-2010, a 56% decrease. Vaccine effectiveness for prevention of infection was 82% based on this study. There were also some impact studies in the primary care clinic setting. Studies in 3 urban primary care clinics showed a reduction in prevalence from 24% to 5%. This is in at-risk sexually active females 14 to 17 years of age. So another comparison of the pre- and post-vaccination eras. There also was a reduction in HPV prevalence in both vaccinated and unvaccinated women who attended primary care clinics, comparing the two periods 2006-2007 to the period 2009-2010. We also have HPV vaccine impact with respect to genital warts, ecologic analyses using health claims data from private health insurance show reductions in genital warts as well, a 38% decrease in females 15 through 19 years of age from 2006 to 2010. And then another study in public family planning clinics demonstrated a decrease of 35% in females younger than 21 years and a 19% decrease in males younger than 21 years. So lastly, with respect to impact, we have data from Australia where HPV coverage is really high. 80% of school-age girls are fully vaccinated in Australia because they have a school-based vaccination infrastructure. High-grade cervical lesions have decreased in women younger than 18 years of age, and the proportion of genital warts cases has declined by 93% among females to 82% among males. So moving from impact to kind of strategies and our call to action, we have a lot of work to do in this country to achieve coverage levels on a par with Australia's. This graph shows vaccination coverage in adolescents 13 through 17 years of age with various vaccines. Coverage has steadily increased for Tdap, that's the blue diamond at the top of the graph. MCV4 is the line with the red squares. It's very good as well. But look at HPV, the green triangle. Coverage is plateauing around 53% for that's one dose only of HPV, and for 3 doses, that's the purple X's. It's even started to drop off a little bit. And then the blue and the orange are coverage levels of vaccine in males, and we are hoping those continue to rise. We've just started to collect data on that, but the lines for females and HPV are quite disturbing. We need to do better. When breaking down coverage estimates by race or ethnicity, we can see slightly improved coverage in Hispanics compared to white non-Hispanic and black non-Hispanics. But I think the overall message in both boys and girls, the overall coverage just remains too low. So we need to do better. There are 26 million girls younger than 13 years of age in the United States. If none of them were vaccinated, 168,400 would develop cervical cancer and 54,100 would die from it. If we vaccinate only 30%, we would prevent 45,500 cases and 14,600 deaths. If we vaccinate 80%, we'll prevent 98,800 cases and 31,700 deaths. So comparing that 80% to 30%, that's kind of our, that's our benchmark. That's where we're looking for that improvement. And for every year we stay at 30% instead of achieving 80% on a year-to-year basis, 4,400 future cervical cancer cases and 1,400 cervical cancer deaths will occur. So what kind of strategies can we use? One, if we vaccinated every opportunity, we can achieve 93% vaccination coverage as opposed to the current 54% coverage. That's what this graph intends to show. Uses the NIS teen data and shows what happens when vaccines are given at every visit, every clinic visit, as opposed to just well-child visits or checkups. We're talking about vaccinating at physicals, sports physicals, vaccinating during sick visits. You can do this with this. You can do this with this vaccine. Avoid missed opportunities. You can give the vaccine at the same time as Tdap and MCV4. You can give it during the routine physicals. Providers should review the record at every single visit, even acute care visits, to see if the vaccine is needed. And always provide documentation to patients and their parents so that they know that they have received this dose and that they need to come back for the second and third dose as well. So I've gone fast and I've given you a lot of statistics. I want to now highlight the perfect storm, why we think HPV vaccine is different from MCV4 and Tdap. some of the reasons it's different. The disease itself, not the vaccine, but the disease brings a lot of, I think the nature of the disease brings a lot of attention. In the media, issues become sensationalized. Unlike other adolescent vaccines, it does require 3 doses for series completion, so that's a big challenge for achieving full coverage with this vaccine. It can be challenging to talk about the risk of disease to both patients and parents. Parents may think sexuality instead of cancer prevention, and so this can lead to clinicians not giving as strong a recommendation as they should. If parents have questions, the providers might misinterpret that as hesitation. Another challenge with this vaccine is the ACIP originally recommended this vaccine only for girls and then added boys later. That can be confusing to parents. The reason why that occurred is that it actually took longer to demonstrate that the vaccine works well in men versus women. You have to show that you are reducing the burden of disease in an actual methodical trial and study, and the disease, first of all, doesn't happen as often in men, so it takes longer to complete the studies, and so that kind of is the reason for the lag between men and women. So any systems intervention to improve coverage rates, I think the most important thing first is going to depend on a clinician commitment. So I want to really focus on this and ways that providers can frame the conversation when talking about HPV vaccine. I can't cover everything. Let me first show you a tip sheet. This is on CDC's website, and I'll show you the URL for CDC's website at the end of my talk. These tip sheets were generated following a lot of formative research that was done in focus groups. Basically, this research links what was heard in the focus groups to the specific message that we think providers should be giving. I usually don't like to actually put words in providers' mouths, but you'll see that in this presentation actually, because we've kind of reached a point where we need to do something and do something quick, because we don't want to let this coverage lag anymore. Studies show that the clinician recommendation, your recommendation, is the most important factor in a parent's decision to vaccinate. Not receiving the recommendation was actually specifically listed as a barrier by mothers in these focus groups. You need to group the vaccines together, the other adolescent vaccines, and recommend them all at the same time. If you don't do that, parents are going to wonder if the vaccine is truly necessary. So recommend this vaccine, HPV with MCV4 and Tdap. Here's a graph that shows the top 5 reasons for not vaccinating their daughter. It's surveys of parents. This is a subset of those parents that had no intention to vaccinate. And so you can see that that not receiving a recommendation, even though these parents seem to be going into the visit with no intent to vaccinate, they still stress the importance of what the provider tells them. So that's a message to all of us as providers that we really have an impact, especially on those that may walk in and are more or less undecided. They were, number 2 on this chart is not receiving a recommendation from the provider. So as far as the words, what you can try saying your child needs 3 shots today: HPV vaccine, meningococcal vaccine, and Tdap vaccine. Your child will get 3 shots today that will protect him or her from the cancers caused by HPV, as well as to prevent tetanus, diphtheria, pertussis, and meningitis. So try using that in your presentation. I think that emphasizing that HPV vaccine is an anti-cancer vaccine is very, very important. In the focus groups, mothers wanted more information on the different types of cancers, and then some were influenced to vaccinate their child because there may have been a history of family cancers or personal experience with cervical cancer. So, you know, you should talk about cancer, and I think emphasize that this is an anti-cancer vaccine. It is true that the fact that HPV is a sexually transmitted disease, you can't escape that fact, so that will come up. But I think leading off with anti-cancer vaccine is one thing you can do. Parents will say, but she's too young to give the vaccine at 11 or 12 years of age. They might believe that their child won't be exposed to HPV because they aren't sexually active or may not be for a long time. In many of the focus groups, moms didn't understand that the child could become infected even if they waited until marriage to have sex. Part of this, I think, is a lack of realization of how common HPV infection is. You know, HPV just isn't as widely known yet as a disease, sexually transmitted disease or a cancer-causing disease. So that realization kind of has to happen as well. So if the parents are saying my child is too young, you know, try emphasizing the risk is real and doesn't only relate to the child, but the child's future sexual partner, someone who the parent really has no control over. Try saying, even if your child waits until marriage to have sex or has only one partner in the future, he or she could still be exposed if his or her future partner has engaged in any type of sexual activity with another person. We don't wait until exposure occurs to give any other routinely recommended vaccine. HPV vaccine is also given when kids are 11 or 12 years old because it produces a better immune response at that age. That's why it's important to start the shots now and finish them in the next 6 months. So this, obviously, this is a challenging conversation to have with, you know, when you just try to imagine having it with perhaps both parent and child in the room, but you're the only health provider, and a discussion of sexuality really has to happen anyway in the primary care setting. I think with HPV vaccine, this discussion will happen, but you should always lead off the discussion and come back to the fact that, and this is a repeat slide, that the HPV vaccine is cancer prevention. We can prevent 1,400 cervical cancer deaths on a yearly basis if we can just raise our rates from 30% to 80%. And I'll emphasize again, it's a vaccine, so it must be given before the exposure occurs. I think with that, I will show you some contact information. If there are any questions at CDC, we have an NIP info email line. CDC info website is a way you can submit questions to a broader hotline service. It may not be as direct as NIP info, but a lot of questions can be addressed through CDC info. And then the last line here is our website, the vaccines portion of CDC's website, where you can then click on the HPV page and find all of those provider tools for talking with parents, because I didn't have time to go through all of them today. So with that, I will conclude, and I'll turn it back over to the moderator.
Thank you so much, Dr. Kroger, for your presentation. It contained a lot of good information, and we'll be sure to highlight all of the tips that you provided to healthcare providers, as well as informing patients and different things. So we'll go ahead and open up for Q&A. For all the attendees, please, in order to ask your question, please type it into your chat box, and then we'll go ahead and get Dr. Kroger that question. In the meantime, while we are waiting for questions to develop in the queue, I just have several announcements. For more information about some of the free training and technical assistance we provide, please check out our website at nchph.org. We have a wealth of information, including fact sheets for residents, which are written at a low literacy level, and some information on cervical cancer as well. If you're interested, please also consider joining our mailing list in order to receive a lot of the information that we send out. Follow us on Twitter. So even during our webinar, we were tweeting some of the amazing facts and stats Dr. Kroger was able to provide to us, as well as some tips. And so if you were to miss the webinar, you can check our Twitter account for some information, as well as check out some of the videos that we have on our YouTube channel. I would also like to announce our upcoming symposium, June 10th through 12th in Alexandria, Virginia. Our call for abstracts is still open, so if you are interested in highlighting some of the programs and services at your health center or through your organization, please consider submitting an abstract, and you can check out our website at nchph.org for more information on that. Also, here is our contact information if you need any assistance. If you need some follow-up after the webinar, we are more than happy to assist you in any way, so feel free to contact us at any of the following email addresses. Let me see what is in our queue. So for our first question, will HPV become a required vaccination among children?
A good question. I guess, first of all, I'll emphasize that CDC only makes recommendations. They don't require any of the routine vaccines, really. But of course, states, it's the state law and school laws sometimes make vaccine requirements for school entry. I believe that I thought Virginia had done this recently at one point. I'm not certain of that, but I think that when the vaccine was first licensed, Texas had some laws that for HPV vaccination, but I think they ended up changing those laws. But I think Virginia now is a state that has an HPV school vaccine law, but this is not by any means national. I can't predict what will happen. I know it's very challenging because human papilloma virus, of course, is not transmitted by respiratory, through the respiratory route. So it's harder to make the argument that you're protecting large numbers of the public by making a school vaccine recommendation. What I will say, though, is that for any vaccine, and I'm talking generally, not specifically about HPV, but in general, when there have been mandates made for the use of that vaccine, coverage rates rise incredibly, so they work. So I mean, they're one of the best strategies that are out there for increasing coverage rates. So it's going to be up to the states to really take that step and make that decision.
Excellent. Thank you. Can or should the HPV vaccine be given to someone who has already had an abnormal pap or tested positive for HPV disease?
Yes, it should be. Because even if they've had a positive, positive pap or a positive HPV DNA test, even the DNA test is not always specific for which strain caused the disease. And for women that have previously been infected with HPV, only 0.1% have been infected with all 4 vaccine strains in Gardasil. So what that means is that the remaining 99.9% have not been infected with all 4 and would derive benefit from the vaccine. And so we do recommend the vaccine for those that have already had a positive test. It will, and there are studies done by the manufacturers that show efficacy against those the strains to which the vaccine recipient is naive. There is efficacy, and good efficacy, again, in the 93 to 98%. So the vaccine does work against those strains. So yes.
Okay. And how often are people screened for HPV?
Right. So there are recommendations for Pap tests, and I think there has been some harmonization recently among the American Cancer Society and the American College of Preventive Medicine and the American College of Obstetricians and Gynecologists to begin doing Pap testing at 21 years of age. And then, I'm not going to get the details right, I don't think. I'm a little worried because there are different organizations that make recommendations. I think that it generally, it starts out at a yearly interval, and then I think after a couple negative tests, it gets stretched out to every 3. But I think it begins. I think some organizations still recommend it yearly, but I think most of the groups now do recommend age 21 for starting to test.
Yeah. And how about for males? Are there any screenings available to detect HPV among men?
Only in research settings, really. I mean, there are. Well, I won't. Not only, but they're not that available. I think certain clinics may have specialized testing. You can do penile swabs that can detect HPV, but it's not done in any routine way, and it's not currently recommended to be done in any routine way. It's not as common among males generally, but for certain high-risk males, men who have sex with men, men who have HIV, that may be seen in HIV clinics or specialized clinics, they may have some resources, but these are not generally available nor widely used. So, and that's been one of the challenges with our recommendations is that it's been hard to collect data on the effectiveness of the vaccine in men because the tests just aren't that common, and so researchers can't do the tests to show that the vaccine works. It took longer to get the data.
Yeah. Okay. And speaking of just STDs in general, are there any vaccines being developed to reduce the risk or the incidence, I guess, of chlamydia or gonorrhea?
I've not. I'm trying to think. I'm trying to remember if there was a chlamydia vaccine being researched. I'll refer for that question. There is on the NIH website, the National Institutes of Health, there is an article called the Jordan Report, which highlights all of the vaccine research that is being done on various for all the diseases for which research is being done. There's no licensed vaccine for neither for gonorrhea or chlamydia, but there may be research being done on those vaccines, on vaccines for those diseases. I don't have any details though. No, we do have vaccine for hepatitis B, of course, which can be sexually transmitted as well, and hepatitis A as well can be sexually transmitted. So those are and HPV really are the ones that we have licensed vaccines.
Yeah. Thank you. Okay, next question. VFC covers the under 19 years of age children for HPV vaccine. Are there similar programs for women and men from 19 to 26, and does Medicaid pay for this vaccine in adults?
So the general answer is there's not the same kind of program as VFC. We don't have the broad program to fund it. I think the manufacturer, when Gardasil was first licensed, I know Merck, and this is before Glaxo had licensed their product, so maybe they both do it now. They had programs in place to help for persons who didn't qualify for VFC, but wanted the vaccine. So those programs did exist. But what I will mention, and this is more of a nuanced point, is that CDC makes the recommendation that, well, first of all, originally they made a recommendation that if you started the series before the 27th birthday, and it's a 3-dose series, if you turn 27 and you weren't finished, we had a full recommendation to complete the series, even if you were older. And we moved on from that to ask the follow-up question, what about if someone is younger than 18 and they start the series and then they turn 19, will VFC cover for completion of the series? And at the time we originally asked that question, there were programs. My understanding is that Medicaid, VFC Medicaid, would cover it, would cover the remaining doses. I don't know if that's still the case, but yeah, I might, maybe a follow-up question to NIP info. I can kind of pursue that further. At the time, though, when this vaccine was first licensed, I was under the it was my understanding that yes, Medicaid VFC would cover the remaining doses in the series. But also, and this is another big point, with and this doesn't relate to the question about Medicaid or VFC, but now that we have the Affordable Care Act, vaccines recommended for adults that are recommended by ACIP should be covered by available private insurance as well. So that's an additional perhaps layer of coverage that might be available.
Yeah.
So.
Okay. I actually just briefly looked it up at cancer.gov, and they said that Medicaid will cover it for people who are under the age of 21.
Oh,
so,
okay.
Yeah, with the ACIP recommendations, they will cover it for people who are under 21, and that also, qualifies for people who are at health centers. So I think that should answer the question. But yeah, we do have a lot of questions, of course, always about reimbursement and things like that. The next question is, will the 2014 catch-up schedule reflect the minimum intervals you talked about, specifically the 12 weeks between dose 2 and 3?
Yes, that has not changed. Those 3 interval groupings, the interval between dose 1 and 2, the interval between dose 2 and 3, and the interval between 1 and 3. Well, actually, okay, so I'm trying to remember. When the schedule was first published, actually, the subject matter experts really didn't want to emphasize minimums. They wanted, because the response is better if you go out a full 2 months before you give the second dose, or I should say 1 to 2 months, because obviously for Cervix the package insert says 1 month, so it's between 1 and 2 months. They recommend that, and then the interval from 2 to 3 will be on the order of 4 to 5 months, right? And that'll generate the strongest immune response. Since then, we have put more information into the schedule. I think we've talked about the minimum intervals. The minimum intervals have always been in the general recommendations on immunization document, which is produced by ACIP and CDC. So they are published, those intervals. But I think the key point is that really those should be used if the dose was already given and you want to know whether you should count it or not. It really is kind of if you're moving forward, you should try to prospectively space out your doses. The challenge, I know one of the challenges has been HEDIS recommendations for managed care organizations, I think, emphasize finishing the entire series by the 13th birthday. And so that opens up the question, which is as yet unanswered, like, if you're catching up to that age, should you expedite your doses and get them all in? It's hard. I can't argue, in one way I can't argue against it. I mean, as long as you maintain the minimum intervals, the vaccine dose is going to count, and we'll, but we don't have a concrete decision on that one yet.
Yeah, okay. Thank you. And for our last question, and this is about the differences between the two HPV vaccines, which one is known to be more beneficial, or which one had a higher efficacy rate?
The Gardasil is slightly higher, but not significantly higher. I mean, the confidence intervals will overlap. The Cervix, there's, as yet, the manufacturers show us data showing cross-reaction to additional high-risk strains beyond 16 and 18. Excuse me. So CDC states no preference in women for one versus the other, since they contain both 16 and 18. And, since cervical cancer, is covered equally by both vaccines, and even though the package insert doesn't specifically list anal cancer, vaginal cancer, vulvar cancer, penile cancer for cervix, those aren't listed as indications. It's the same type. It's the same high-risk type. It's just that manufacturer didn't officially study those lesions. There's no reason to think it wouldn't work against those other types of cancers as well, because it's the high-risk types contained in that vaccine and in both vaccines. So what you lose from cervix is the genital warts prevention, because you don't have 6 and 11. But for cervical cancer prevention, which is really the focus of all of this, CDC does not state a preference between the two vaccines for women.
Okay. Excellent. Well, thank you so much, Dr. Kroger, for joining us today for this very informative webinar. We really appreciate you taking out the time to educate us more on ways we can improve the health of our patients. So I will go ahead and just reiterate that the PowerPoint slides and the webinar is recorded, and we will be sending those out after the webinar, as well as posting them to our website, and you'll have those links available in the next couple of days, so check back for that if you don't get the email. But thank you again, and you have a great day.
Thank you.
All right, bye.